I'd like to introduce our presenters today. We've got Ray Rochester. I'm sure some of you have seen Ray before present, and he'll be on a video today, and also Lucy Leonard, who is live, I can assure you, and there we go. And Lucy will be taking through the bulk of the content today, and I'm sure many of you know Lucy either through these webinars or through her dealings either directly with her or through the OT service. So great to have Lucy on board today. And that's it from me. I will come back towards the end just to give you a few pointers on key contacts and also the Q&A. And I will speak to you later, but I'll now hand you over to Lucy. Thank you.
Thanks, Stephen. Good morning, everybody. It's nice to see so many people here to listen to me talk about what is probably quite a dry subject. So like Stephen says, those of you probably seen me before, but if you haven't, my name's Lucy Leonard. I'm an occupational therapist, and I'm also the clinical director with the OT service. Although I mostly work in private practice now, I am responsible for assisting a number of local authorities with their DFG assessments and waiting lists. So I'm using my experience over the last sort of 22 years working in local authorities and housing, but also some more recent up-to-date information that I've gained from working with local authorities to assist them. So you've probably been sent the learning outcomes, but we're just going to sort of reflect on the changes to the DFG guidance and how they might impact processes or standards. We're going to consider what stresses there are on services at the moment and what impacts these might have on our clients and on ourselves. And we're going to review the current sources and the challenges of meeting the demands of our assessments. And please do answer any questions, because there will be a little bit of time for me to sort of review what questions have come in and try and answer any questions that might come up during this sort of 30-35 minutes that I've got. Okay. It's really important to say that the DFG policy and guidance and administration of the Disabled Facilities Grant is devolved. So that means that it is different in England, Wales, Scotland and Northern Ireland. What we're going to be focusing on today is in England, but there are websites that you can go on to find out more information about how it works slightly differently in the devolved governments. And I know the Royal College of OT have got some information on their website as well. So going to cover a little bit on the DFG legislation, including the recent update which has come out, which I've got a hard copy of here, which is never too far away from me. And we're going to think about the waiting lists that are currently probably quite severe, and consider whether this is this a new thing or is it an exacerbation of a problem that's ongoing anyway. And then we're going to think about the impact of this on our services and the delivery of what we should be doing as occupational therapists. So I'm presuming that you are on this webinar because you might work in housing with adaptations. So you should know what the DFG is, the Disabled Facilities Grant. So I'm not going to go into the great big detail on this, because obviously the time is limited, and I want to give you some more new information and help you to reflect on your current practice rather than going over what you may know already. But just to reiterate that the DFG was introduced in the Housing Grants, Construction and Regeneration Act in 1996, and it had the aim of making changes to a person's home so that they can continue to live there for longer. I think what we should be considering as occupational therapists is that houses are more than just bricks and mortar. So think about the importance of home to yourself as a person, as an occupational being. And when you say the word home, what does that mean to you? It's, for me personally, it's a place that I spend time with my family. It's a place that I feel safe in, and it's a place that I enjoy going back to. And whatever you think about home, think about how your patients and clients might think about their home. So as occupational therapists, we need to think more than just the physical built environment, but the impact of home on your ability to carry out your daily occupations and your life roles. That's something that's essential to us as occupational beings. So it's quite in the act, it's quite plain saying people can live there longer, but to us as occupational therapists, it means so much more. So the Disabled Facilities Grant is a mandatory grant, and it is the only grant available via legislation for adaptations. There are other monies available that local authorities can access. There are charitable monies that we can access. I've worked in the past with people like Help for Heroes and SAFA and the Royal British Legion, but the DFG is a mandatory grant. And it's really important to think about that money and how many times we hear the housing department say, we're running out of money, we've run out of money. That's not a lawful thing to do, because the grant is mandatory and it is in legislation, it's built within legislation. So local authorities should be looking at where they spend their money and moving that away from non-essential things to assisting people with the DFG to enable them to live safely and independently at home. We should know that it is a means-tested grant, so that means that people's income and savings will be considered when applying for a Disabled Facilities Grant. There is, on the Foundation's website, there is you can go through and actually check the means test before you apply. So sometimes if I go and do an assessment and I don't want to discuss somebody's personal circumstances and their finances, I point them in the direction of the Foundation's website, where they can go in and put their income and any savings they have and benefits they may have, and that will give them an indication as to whether they will be eligible for the Disabled Facilities Grant. And that can help really early on in the process, because sometimes if there is a long waiting list for the DFG means test, then they can go on early and do that themselves. So that's empowering the client as well. The DFG should be tenure blind, which means it doesn't matter if you are in a housing association property, a private rented, owner occupied, almshouses, anything like that. The Disabled Facilities Grant should be applied in the same manner for everybody. That doesn't always happen, I know, but that's what it says in the legislation. And obviously the four main words in the DFG legislation are necessary and appropriate and reasonable and practicable. And I cannot tell you how often I have conversations with the occupational therapists that I work with and support whilst I'm working with the OT service, and with the housing department, and with any managers that are challenging clinical reasoning. It's up to the occupational therapist to decide what is necessary and appropriate for that person. And that comes down to absolutely robust clinical reasoning. It is not up to the local authority to challenge your clinical reasoning. And that's why I say it's got to be robust, because I know from experience all of the time our clinical reasoning for recommending particular adaptations can be challenged, because the local authority act as gatekeepers for that money. And they have pressure to spend the money in certain ways, not go over budget, etc., etc. But we have to act as advocates for our clients to ensure that they can engage in their chosen occupations, that we enable them to keep independent, and we fully understand that person as an occupational being, and therefore we can recommend to the local authority what is necessary and appropriate for that person, obviously within the restraints of the legislation. It is then up to the local authority to decide what is reasonable and practicable to provide. And what sometimes people don't realise is that actually relates to the built environment. So an example would be, I'm just trying to think of a real life example that I have used. When I was working with children, I had a case where we made an additional bedroom because 2 children were sharing a room. One had behavioural challenges. So we applied for the grant to make it an additional bedroom. The only place that bedroom could go was in the loft. So they actually did a loft conversion under the grant legislation. Now, that particular case became very close to not being reasonable and practicable. And I'll try and summarise it quickly because it's a very complex case. But what happened was, because the only exit for that family was through their kitchen from upstairs, building regulations said it was a high risk area. And so to grant the planning application, they said you would need to put a sprinkler system into the house, which meant that we had to get a tank of water and put it in the loft, attach it to a sprinkler system in order to have the grant for a loft conversion for a child. So it became very, very expensive. It was getting this tank of water into the loft became very expensive. And it came very close to the local authority saying this is not reasonable and practicable to adapt this home because of all the extra additional things that need to be done before we can make it suitable for the child. However, we worked very, very closely together, and we did actually do this so that they did put in this sprinkler system, and I'm absolutely sure they'll never use it. But some different local authorities who maybe I didn't have as good a relationship with could have just said, you know what, it's not reasonable and practicable because of the way the building is. So that's just a quick example of reasonable and practicable. So we need to think about the necessary and appropriate nature of what we are recommending. And I'm going to talk through the changes in the DFG guidance, which I'm hoping that once you've been on this webinar, if you haven't already had a look, you will go on to the Foundation's website and have a look at the new guidance. I've got a hard copy here, which I'm very, very fortunate to have, and it is well thumbed, and I've made notes in it and things. It's going to be like a Bible for anybody who is working in England under the DFG legislation, because this is going to help you with your clinical reasoning. In 2018, a review was conducted by the University of West England, and that resulted in the publication of an external report. And one of the recommendations was that new guidance should be set out with expectations for local authorities that administer the disabled facilities grants and the rights of a disabled person making an application. And that's where this new guidance that I'm going to talk you through came from. So that's a picture of the hard copy of the guidance. It was published in March 2022, and I know that Foundations have provided some really, really good webinars, and there's lots of information on the Foundations website, so I would point you there. You can download this. I would say it is very readable. I'm looking at it here. There's lots of information in there. I would just say, if you are working under the DFGs, go and have a look at it, because it will be really, really useful for you. If you can't get hold of a hard copy, you can download it. And what it did do is it provided clearer guidance on who is eligible for a disabled facilities grant. And it says this includes autistic people, those with a mental health condition, physical disabilities, learning disabilities, cognitive impairments such as dementia, and progressive conditions such as motor neuron disease. It includes those suffering from age-related disabilities and can also include those with a terminal illness. And what I like about that is that I think, thinking back sort of over maybe 10 or 15 years ago, the Disabled Facilities Grant was really focused on people with physical challenges and physical disabilities, whereas this new guidance has brought in cognitive impairments, mental health conditions. And although it mentions people with autism, I think it could go further and maybe mention sensory issues, because as somebody who's worked with an extensive amount of children in their home environments, I find that children with sensory impairments and sensory challenges and sensory needs had increased significantly on my caseload. And in addition, people with dementia often have sensory needs. So that's great that the definition of who is eligible has become a lot wider. So the new guiding principles that are that have been put into this document have been taken from the 9 principles that Hayward said in 2004. And one of the most important things that I do talk about a lot on these webinars with Closomat is about dignity. So the need to retain or restore dignity. So adaptations can do so much around a person's dignity, especially toileting, especially if we have family members assisting with personal hygiene after somebody's used the toilet. It's absolutely essential that we can support somebody to go to the toilet in a dignified manner. It is not dignified to use a commode in a living area, in a living space. It is not dignified to expect somebody to do that. It is not dignified to expect somebody to strip wash in a kitchen. I've recently seen a client who is being wheeled through from a living room to a kitchen to have a strip wash at the kitchen sink. That is not dignified. Adaptations are there to have, should somebody's needs, somebody's values should be recognised as part of any adaptations that we're doing to somebody's property. So that's where it's really important to get a good rapport with the client when we first meet them and actually understand what they value as a person. I talked about my values, about what home means to me, and they're my values. The need for relief from pain, discomfort and danger really takes us away from a medical model. So I think we need to be considering somebody's well-being when we are recommending adaptations. I think the danger bit might come in again, like I mentioned, with sensory issues and children who might have behavioural challenges. And obviously, as occupational therapists, one of the things we do is we remove those barriers to independence. And we do place a lot of emphasis on independence when we are recommending adaptations. And I think these 2 last guidance, the guiding principles on this page, there are some more on the next slide, need to come almost hand in hand. So it is challenging when we're working with local authorities to give people choice, because sometimes it feels like, as an occupational therapist, we are pushed into a corner and only recommend certain things. And how can we give our clients and our patients choice when we have a limited amount of money and we're working to maybe push through adaptations that we believe will benefit somebody? But I think if we don't give somebody the element of choice, it can end up causing us more problems. And I can think of many examples of this where I've gone in to do an assessment after possibly another occupational therapist has, a number of years later. And I know there was a child that I went to see, and they had a downstairs bathroom, ensuite, and there was a level access shower, and the child had had a disabled facilities grant to provide those things. And the child, when they were being showered on the changing table, because they didn't like it, they would go into spasm, and it would cause the child distress and mum distress. And when I got there to do the assessment, mum admitted she'd been carrying the child upstairs to use the family bath, which was just a standard bath. And not only was that putting her and the child at risk, but she was actually pregnant by the time I'd got to see her. So we ended up removing the shower and putting in a height adjustable bath. And I think if that had been discussed as a choice in the beginning, rather than just thinking that the cheapest option or the best option is a shower, then that might not have happened. So we need to give people the element of choice when we're talking about adaptations, because it really does. If people feel that they can choose the adaptation, they're more likely to use it. And again, that comes hand in hand with the need for good communication as part of giving choice. One of the new guiding principles was the need for light. And it's really interesting. I was kind of been reflecting on this a little bit whilst because I mostly work at home, and the importance of light. So I know when we're working, it's, if you ever have to, I mean, I used to hot desk and I used to go into all sorts of rooms in medical centres and things that didn't have any natural light. And it really does have an impact on your sort of well-being and how you feel. And I think that's really important at home. So it's great that they've said the need for light is within the guiding principles. And the last two principles, again, come hand in hand. It's the particular needs of children to provide for growth and change, and the need for space. We need to think about other family members and the family as a whole. I have worked with local authorities that say we don't do extensions. First of all, that's not lawful to say we don't do extensions. But what has been happening is that if somebody has, say, for example, a dining room, they've been told that has to be used as a bedroom. But we need to think about other members of the family and the family as a whole. And we need to future-proof adaptations, especially when we're dealing with children, because the means test kicks in when they're 18. So when we are dealing with children, we should be planning for the future and making sure we're taking into account the entire family. And like I say, it's very easy for me to sit here and say, you know, we should be doing extensions rather than changing dining rooms. And I can't see the chat box at the minute, but I can imagine people are saying, well, we just can't do that in our area. But we need to assert ourselves. We need to advocate for our clients, and we need to clinically reason what we're doing, and act as leaders at all levels of whatever organisation you're in, and challenge as well. We need to be able to challenge any decisions that are being made which we don't think are lawful. We are not gatekeepers for the DFG monies. That is not our role. Our role is to go and assess what is necessary and appropriate. This webinar is about DFG waiting lists. I'm just aware of the time. And I need to kind of move on because I want to talk about some of the challenges. But in the new DFG guidance, there are some timescales that are mentioned, and they talk about different stages. Actually, 5 stages in total. Stage 0 is when the referral comes in, however that comes in. So when the person or the family member or the health professional makes contact, that's stage 0. So stage 1 is the referral time to assessment. And what the new guidance says is that if something is urgent and simple, the referral to assessment time should be 5 working days. So have a think about your practice and have a think about whether that to you is achievable. So an urgent and simple adaptation might be something like a hospital discharge and somebody needs a straight stair lift to access the first floor. So that sort of first floor toilet. So that should be assessed within 5 days under the guidance. Stage 2 is when identify the irrelevant works for the OT assessment. Stage 3 is the grant application to grant approval. And stage 4 is approval of grant to the completion of works. So for an urgent and simple adaptation, the total is 55 days, which is actually 11 weeks. For something that's non-urgent and complex, the total is 180 days, which is actually 36 weeks. So although they look quite short in terms of days, it's actually quite long in terms of weeks. So I'd be really interested to know how you can reflect on this guidance. So this isn't in law, this isn't legislated, this is guidance. But I think we need to think about how appropriate those timescales are, and whether you as practitioners from wherever you work would think that that would be achievable. So your referral to assessment time for a non-urgent and complex adaptation would be 7 weeks. So a maximum of 7-week wait for an occupational therapy assessment. Now, what I'm finding at the moment with waits for occupational therapy assessments is they can be 12 months plus, and in some cases, especially for children, can be over 12 months and sometimes over 2 years. So just have a think about what your waiting times are for an occupational therapy assessment in your area, and what maybe we can do about that, and what can be done about it. So the questions to consider are those timescales realistic? And who do the timescales benefit? What are the challenges in meeting them? And do they impact on how occupational therapy services are delivered? So are the timescales realistic? I think that depends on a number of factors. I think that depends on staffing. I think it depends on what processes there are. Having now worked with a number of different local authorities, sometimes there seems to be steps in a chain that don't need to be there. So I think that's something that we need to consider. Timescales in terms of getting an adaptation in. How quickly can we get a stair lift in? How quickly can we get a Closomat toilet in? Is there going to be a wait further down the line? Could we get out in 5 days to assess somebody? But actually, when we recommend an adaptation, can we not get hold of a local sales rep? Is that going to hold things up? Are they really busy? Is their diary busy? I actually spoke with Closomat before this presentation, and they said that they can get a Closomat toilet to use supply only within a couple of days, and supply and fit within about 10 days. So that would fit within those urgent and non-complex timescales, and certainly would fit within the other timescales. I think the challenges in meeting things is things like materials that we're struggling to get hold of at the moment. I know I had an adaptation and we were waiting for stainless steel to come in because there was a shortage of stainless steel. So there are going to be lots and lots of different challenges around those timescales. But I think we as occupational therapists have to do our best to break down any of those barriers. But there are going to be times when things happen that are completely outside of our control. So I'm going to talk quickly about waiting lists and the current challenges that we face. So like I mentioned at the beginning, we're working with a number of local authorities at the moment that have quite significant waiting lists. And I think there is a real problem with recruitment and retention at the moment. There are lots and lots of people leaving social care due to terms and conditions. As we know in the NHS, they are talking about strikes because of terms and conditions and pay. So there are many, many difficulties with recruitment and retention of staff. And this isn't an accurate way of looking at vacancies, but I quickly went onto the NHS jobs website and typed in occupational therapist, and there are 1,491 occupational therapy job vacancies online at the moment, which is incredible. It's yeah, like I say, it's not it's not an accurate picture, but it just shows how many vacancies there are out there for occupational therapists. And I found a report published by the UK Parliament this year, and it says wider market forces, including the rising cost of living, lack of affordable housing, lack of transport in remote locations, are having an impact on recruitment of retention of health and social care workers. And they will manifest themselves differently across the country, but it says that without action, the NHS and social care sectors will continue to struggle to recruit and retain staff. I also found some statistics that said waiting lists in social care grew 37% in 6 months from November 21 to April 2022, from 396,000 to 542,000. Now, consider the impact of COVID and what that has had on waiting lists. If we think that this from November 21 to April 22 is not what we would think was in the pandemic. So waiting lists are still going up by a significant amount. That report also said that 74,000 people are waiting over 6 months for an assessment, which is just incredible numbers. But I also found some statistics from NHS England and NHS Improvement from January this year. And it said that over 900,000, that's nearly 1 million, children and adults are waiting for services as part of community services care backlog. And one of the most significant waits are for community paediatrics, occupational therapy, and especially those with suspectable autism and ADHD. So that's a lot more than the other report that I found. So at 900,000 people waiting. Put on top of that the number of vacancies, the amount of people leaving, we are in a lot of trouble. I do also think there is an impact on DFG waiting lists, which isn't a new thing, but it's about the complex commissioning contracting arrangements. Having worked with some local authorities, a lot of people are falling down into gaps where then we're saying we're not commissioned to do this, and we don't see that type of client because they are funded by that. And people are getting passed around a little bit because there isn't an agreement about who should assess that person. I can give you an example of those who are funded by continuing healthcare. There is sometimes a discussion about who is the best person or who is the contracted person to do that initial assessment. And obviously during the pandemic, a lot of community services staff were redeployed into hospitals. And although that was absolutely the right thing to do at the time, there's been a real impact on children's services, which we are seeing now, and children are waiting an incredibly long amount of time for an assessment for adaptations. So I mentioned foundations earlier, and we could be here all day talking about the solutions. And I do want to be able to answer any questions or pick up some points maybe that you've raised during the webinar. But I would point people back to the foundations website where people can do a self-assessment tool, and I've put the link there, and it's adaptmyhome.org.uk, and people can go on and put information about their home and it would tell them whether they're going to benefit from adaptations to help them stay safe and independent. So there's a little bit of sort of self-screening that people can do. I mentioned about the means test calculator as well, which if you don't know about it is very much worth sharing with your clients to see if they are going to be eligible for a DFG. And then there's other things that we can look at. Stephen mentioned before about Closomat sales specialists that are trained as trusted assessors, which may help to reduce the number of visits that you have to do jointly with them. Obviously, you would clinically reason which ones you would need to do with them jointly and which ones not. So that's a fantastic scheme for helping to reduce the number of visits that we need to undertake. There's a lot of work done around patient activation. It's a concept that came from America, but it's about a self-care model where people actually, their health and well-being is has found through research to be better if they take more control over themselves and their healthcare, and they have more knowledge. And there's something called the patient activation measure, which if you're interested, go and Google it, which is a test that you can do with your clients to see how activated they are. There's things like the Sunflower Programme and parenting groups to assist families with children with sensory needs, to not only just help them to adapt the built environment, but actually address some of those sensory needs that that their children may have. And obviously, the NHS are looking at striking over around December time. You know, one of the solutions is better terms and conditions for health and social care staff. And that's something that can't be ignored, but that's something that has to be taken at a political level. And then finally, it's worth saying that the OT service have taken some work from local authorities. More and more local authorities are looking to outsource some of the work, because having worked in the NHS and local authorities myself, I know the impact of having that waiting list has all the time. You're aware that your waiting list is there. So some local authorities are outsourcing those assessments to companies such as the OT service, and they can concentrate on those urgent clients that need to be seen quickly. And what we do at the OT service is we work very much in partnership with local authorities and the NHS, and only use specialist occupational therapists to assess people's needs at home. And then we work in exactly the same way as a local authority occupational therapist. We can use the same IT systems if required, and we can make recommendations for DFGs, which are then carried through by the local authority. And what we can also do is, using our knowledge and our skills, is advise the local authority and occupational therapy staff about some of their processes that might be holding up and causing more problems with waiting lists. So that is a whistle-stop tour of the DFG's waiting list, the new guidance, how that might impact. There's so much to get through in such a short amount of time. I would like you to go away and reflect on what I've said, and maybe do a little bit of research yourself. Go on the Foundation's website, take some of the advice that I've given you, certainly do a bit of bedtime reading, it really is worth it, and go out there and share this information to make things better for our clients and patients and the people that we work with. So I am now going to hand over to Ray Rochester, who is the Regional Sales Manager for Closomat.
Hello, my name is Ray Rochester and I'm a Regional Sales Manager with Closomat, and I will spend the next few minutes taking you through some detail on Closomat, the company, the products and services. Firstly, if you haven't seen it before, this is our company vision, part of our core belief and something that every representative and employee of Closomat subscribe to. It is absolutely why we do what we do every single day. As you probably know, Closomat manufactures the Palma Vita Closomat and a wall-hung version, the Lima Vita, and has been doing so in the UK for 60 years now. As well as that though, you may not be aware that Closomat also supplies, installs and maintains a wider range of products as shown on your screen now. The most commonly specified Closomat is the Palma Vita. There are now over 60,000 Closomats in use in the UK. The product is the UK's most commonly used wash-dry toilet. It was the very first of its kind and remains the only wash-dry toilet designed specifically for the disabled adaptations market. Of all the wash-dry toilet options available in the UK today, the Closomat has the most effective wash and dry performance, using up to 8 litres of water a minute sprayed directly at the area it is intended to clean. The products can be adapted to suit the client's need with a range of heights, alternative seats, operating methods and supports to suit everyone from a paediatric to a bariatric client. As standard, the Closomat will support a client weighing up to 30 stone. With the Big John seat fitted, it can support a client up to 57 stone. And then Palma Life, a relatively new concept in toileting, uses the very same toilet and accessories, but is sold with included annual service and warranty for 10 years from the date of install. This gives peace of mind for the client and also for the specifier. At Closomat, we work extensively to take all responsibility away from you for all aspects of specifying the wash-dry toilet. Our nationwide team of assessors are now trained to Trusted Assessor Level 4. They will carry out an assessment of the property, the client and the bathroom. Often this begins with a telephone triage before a decision is taken to visit or carry out a remote assessment. Our assessor will prepare a product specification based upon the needs of the client and to suit the environment, sometimes including an installation survey to identify any challenges that may cause an issue during the installation of the product. At Closomat, we also offer a no-quibble guarantee. This means that as long as we have carried out the product assessment, that we guarantee that the product specified will be suitable for the client given their current situation. So if, for example, we specify an incorrect height of a toilet or the wrong seat, we will rectify the error at no further cost to the LA or specifier of the product. As mentioned a moment ago, regardless of how complex the need, our process is followed through from triage to assessment, noting that all on-site assessments follow our COVID-secure procedures. Following the assessment, a written quotation is provided for your consideration. We also take responsibility for the installation. That's simple if we're doing it ourselves, but where we are not, we have developed an online installer training program to ensure that whoever fits the product installs it in the safe and correct manner. We also take responsibility for commissioning of every installed Closomat. This is more of a customer care visit during which we will make adjustments to the toilet to make the experience better for the client. At this visit, we can adjust the water temperature and pressure to suit the client needs. We can change the wash and dry times and operating methods as well. To encourage the installer to notify us of the installation immediately or as soon as possible, we have introduced QR codes on the product and packaging so that it is much more efficient getting that information to us. We also commit to carry out that commissioning visit within 10 days of install. Talking a little about service and warranty, it's important to understand there is a major difference between warranty and service warranty. If you use the analogy of a car, if you buy a car with a 5-year warranty and simply drove it around every day and never had it serviced, the likelihood of breakdown increases. If you have the same car serviced every year, you would know that at the point of service, the vehicle is in full working order and the likelihood of breakdown is greatly reduced. At Closomat, all of our service and warranty packages include an annual service of the product by one of our employed engineers. In the unlikely event of a breakdown, often the very same engineer attends to repair the product, and as his vehicle is fully stocked, first-time repair is carried out in almost 100% of cases. This level of service and warranty protects the asset and reduces the likelihood of having to replace the product. From a client's perspective, it also means that they are less likely to suffer from a loss of use of the product, and it means there is less of a burden on you, the professional, and your contractors having to respond to product issues. So once you buy from Closomat, you're done worrying. This is because everything we do, whether that be assessment, advice, support, training, product, service, and warranty, are designed to take all the worry and responsibility out of your hands. Thank you very much for listening. Hello, my name is Ray.
Thank you, Lucy, and thank you, Ray. I think that's been a really, really thorough investigation, really, of the issues I know that are out there, some of which we can't control, but hopefully you've seen some really good examples from Lucy of where certainly they can help and we can help as well. And all of this material will be sent to yourselves, so everybody who attended today, you'll get a copy of the presentation. What I would also say is if you subscribe to our YouTube channel, as soon as the video is available of today, that will be on our YouTube channel and in any other videos we do as well. And by subscribing, you automatically get told when there's a new video on our website and via our YouTube channel. So do subscribe where you can. I know we've had a number of people post the webinars that have been doing that, and I know it's benefited them to see when there's new content available. In terms of our webinars going forward, we will let you all know of the 2023 now series for next year. We'll have unlikely to have a change in the format, so it'll be quarterly and also the learner lunch sessions that we have, which I know a number of you attend both, and we will let you know as soon as. But again, check on the website, but also if you subscribe, we'll be able to let you know when those webinars will be up and running. So again, we look forward to seeing you in 2023. So if you want to find out more from us, if there's anything you need, then do email info@closomat.co.uk. The live chat as well if you've got any questions. And of course, there's our website. And do go on the website where there's a wealth of information that can really inform both product, but also information regarding disability and how we feel we can help that area as well. Also on our website, a list of our product assessors. So you'll go on there and you'll be able to find the product assessor in your region and contact details if you need to contact them directly. So again, if you can't find them on there or you're not sure who it is, just email info@Closomat and we'll ensure that's dealt with quickly for you. So the final thing really for me is any further questions. And at this stage, I usually open it out to the floor and to ask whether there are any questions in the Q&A that perhaps we didn't answer, or perhaps that we were going to share with the group. And really, this is probably Robin in the main. If there's anything, Robin, on there that you felt it was worth sharing.
There's been a lot of chatter, and I've really loved to see all this interaction between the delegates that have been on, chatting between themselves as well as posing questions, which has been fantastic. So I've got 3 questions that I've made a note of that I just couldn't answer, Lucy. So over to you. So Michelle asked, would the local authority looking at access for the builders fall under their decision whether it is reasonable or practicable?
Access for the builders, I'm presuming they mean in terms of safety. I'm not quite sure.
I'm not sure.
I think it's within the gift of the housing department to decide what is reasonable and practicable. So there's going to be some interpretation of the legislation under those words, but I think if the local authority did have, or the housing department did have, issues about access for builders, I would say that they could use that part of the reasonable and practicable part of the legislation to back up any decisions that they were going to be made. But I think any decisions like that have to be really robust and carefully thought through, and done in conjunction with the client, the occupational therapist, and anybody else that's relevant to the process.
Okay, hopefully that answered that for Michelle. Tracy asked, for anyone in Wales, where can they access the version for them?
Well, that's very interesting that you say that. I recently did delivered some CPD in Wales, and I went and did some extensive research to see if there was anything similar to the guidance for England, but I couldn't find anything. I actually did contact somebody in the Royal College of OT to see if they could help me. I didn't get a response, so you've just reminded me that I need to chase that up.
Right.
But I would go to the professional practice inquiries, possibly, for the Royal College of OT, if you are a member. Hopefully you are, and they should be able to help you with that. That's what I'm going to do. I'm going to chase it up. But as far as I can find out, I haven't found any similar good practice that's been published for Wales, unfortunately. Sorry.
Well, if they get a raft of inquiries, they'll have to do something.
Yeah, they will. They definitely
Spam them.
will.
And lastly, Rahana, I think the name is, do you consider adaptations to children with ASD behavioural challenges, even if they have not received support from other services such as CAMS or an LD, to address some of these challenges prior to adaptations being considered? Did that make any sense?
It makes complete sense, because I absolutely fully understand the question, having worked with children extensively with these issues. So there's a bit of a juxtaposition where we can use a compensatory approach, can't we, and adapt the environment if children are having behavioural problems. What I think we need to be very, very careful in what we're doing is that if children are at risk, we can't just say we're not going to adapt because you've not been seen by CAMS. I know that this has in some places progressed quite far in terms of complaints, etc., where a child has been turned down for adaptations because they've not been seen by CAMS or learning disability, and they were banging their head and putting themselves at risk. So what I would say is, yes, it needs to be a collaborative, holistic approach to the child and their behaviour, but I also think we need to look at risk. And if the waiting list for CAMS is 2 years and we can go out and adapt the property now, I think we are under obligation to make that home safe. And that is within the legislation as well. It does say part of the DFG is for making the property safe. So I have done numerous adaptations, including fences, padded rooms, stable doors, etc. The amount of things that I've done for children with behavioural problems, because there has been a risk identified. And actually, if that child does grow out of that behaviour, well, then that's great. But I think we just need to consider the risk and reduce that as quickly as possible.
Thank you. Not a question, but just a comment to everyone that's still on the webinar. That Susan Wright, who commented about her pre-referral checklist, will support Susan with all the requests for all the people that have put in the chat their email address to get that. We'll support her so that she will be able to contact you all and provide that information, because obviously that's really very popular, and that's what's lit the chat up. So that's fine. We'll support. So everybody that wants that will get that.
That's brilliant. And can I just say, I've not managed to get into the chat because I've been presenting, but just thanks to everybody for sharing that kind of information, because on a webinar, sometimes when I'm presenting, like I was at the OT show, and you can bounce ideas off people and people can come and chat with me, because I could chat about this all day. So thanks for interacting in the chat there. It's really helpful, and we continually learn from each other, which is great.
And somebody's put in the chat, Cressida, thank you for the name of the RCOT rep in Wales.
Oh,
so
great.
that's good as well. So thanks for that.
There we go. There we go. That's brilliant. Thank you.
That was it, Stephen.
Okay, brilliant. Thank you, Robin. So that's it from us for this year, actually. And thanks for everybody for attending over this year and last year. And I know we'll be similar events next year, and we hope you can all attend those. I hope you're all able to have a decent break over Christmas and come back refreshed, as I know we will. Hope you get to enjoy that break. And like I said, anything you need from us, do let us know. We'll send you this information. We've got the various contact details on there. But just say one final thanks to Lucy, to Robin, to Kirsty for today. Again, as always, some fantastic content on there. And we look forward to seeing everybody in the new year. Thank you.
Thanks, everyone. Bye. Merry Christmas.
Thanks. Bye, everyone.
Thank you. Bye.